not gone anywhere. So in this case, you've got a stable bag really because of capsular tension ring in place, but you've got that vitreous strand. This is an old video showing the actual use of a 23 gauge cutter. They are much larger, bulkier, autoclavable. This came with a Sovereign compact machine, requires a 2.8 incision, and because the irrigation and aspiration are not dissociated, you see the forces oppose each other. I'd like to touch upon, is there any role for scissors vitrectomy, especially for surgeons wherein you are still doing SICS and don't have a vitrectomy unit. This patient had a zonular dialysis for which a CTR was put, and at the end of which an iris sweep showed you that you actually have a peak pupil. So with angled Barners, which is sharp, which is properly autoclaved, sealed, ETO'd, it is safe to still today do a proper and thorough anterior vitrectomy should you not have a vitrectomy unit with you. At least we should know how to do it, right? Now, you may think that it's just a strand, like I'll show you in this case. So at the end of putting in the lens, we noticed that there was a peaking of the pupil there. Since there was no obvious PCR, I thought it was a zonular dialysis. Clearly, there was a peaked pupil and there was a strand of vitreous which is now cut. At the end of cutting that little strand, it's always good to put in some pilocarpine and see what happens. Why I'm showing you this is so that you understand that in intraocular scissors does not allow for an effective vitrectomy. If at all it has to be scissors, it has to be angled Barners. Putting in triamcinolone shows you that it's a lot more than a vitreous strand. Now, under viscoelastic, because I want space for my instrumentation, the vitreous is first cut from the wound. I approach the vitreous always from the opposite side to gain a little more access to the vitreous. And you can see in front of your eyes all the triamcinolone stained vitreous getting cut. We cut it always at the pupillary plane. And at the end, that peak pupil does come down, right? So some things might be slightly repeated, but there are a few points I'd like to make. This is a patient who was seen on day 1 post-operatively with disturbed vitreous in the anterior chamber. So you make incisions large enough to allow for your cutters. With a 23 gauge cutter, 23 gauge MBR is enough. Again, always stain with tricot, because that shows you exactly how much and that you don't end up, missing any vitreous. So here's the strand. In fact, there are 2 strands here. I put in some viscoelastic, and when you talk about cutting an isolated strand, I think, and this is another important point, sometimes I find with a 23 gauge cutter, tilting the eye towards the side of where the vitreous is prolapsed to gain access gives you a little more, access of going and cutting the vitreous. Remember that we are not going to use a vitrectomy every day. This is a cutter that has been used off-label, ETO'd, reused and reused. There's no way when you reuse a cutter, you know whether it's going to be sharp enough or no. So it would be preferable, you can see here, I'm going on cutting, I'm doing it correctly, but it's just not cutting. So you should aim to use a new cutter each and every time. You're not going to use it that often. You want to have an effective vitrectomy. All strands need to be cut not nearer the incision or in the middle of the anterior chamber, but at the pupillary plane itself. Now, what if you've got a blob of cortex floating around in the anterior vitreous? Sometimes at the end of the surgery, we go behind the IOL in the cut eye mode, only the cut eye mode, to remove either some bit of vitreous or some cortex. Now, at that point, you don't chase this cortex that's there, but should it come to your port, you can just keep cutting it and aspirating it. It saves you referring it to the VR surgeon. Now, coming to the proper automated anterior vitrectomy. Now, this patient is a case of a polar cataract, and at the end of nucleus management noticed a big opening in the PC. The aim of using triamcinolone is to stain the vitreous in the anterior chamber because it sticks, it doesn't stain it actually, it sticks to it and delineates it. When you want to cut the vitreous, you have to go in the cut eye mode. I would advocate using a cut rate of about 1200 to 1500 and a vacuum of about 150. Make sure that the vitreous is cut from all the incisions, not just one of the incisions, but all the incisions. Then the source of irrigation is introduced into the eye, and then the cutter from the opposite side. as we proceed with the vitrectomy in the anterior chamber, you have to ensure that the cutting tip always is in your view. As long as you're seeing what's happening, you are in control. Make sure that your tip doesn't face to the side where you can accidentally damage the pupil or the anterior capsule, nor the posterior surface, because that's not what you're aiming to clear any which way. And then you cut the entire vitreous in the plane of pupil. Once I'm done with cutting it in the plane of pupil, sometimes I go in the area of up to the level of the PCR and I cut there as well. You have to make sure that you have that much control that you do not ever endanger the anterior capsule, because that's going to be your support system for placing the lens. Now, in this case itself, I'm using a 23 gauge cutter, but there's a very thick epinucleus there. So what I need to do is, I do not need any vitrectomy, that is cutting of the cutter, to remove the epinucleus. So I now go in the IA cut mode, wherein I use the same vacuum, but the cut rate is down to only about 400, which comes up right at the end. Sometimes in a very, very thick epinucleus, I may need to use a little bit of cut at the end of the aspirating it into the center to aid its appropriate aspiration. And I think it's safe to keep your aspiration what we would do during IA itself, because we are familiar with pulling on the cortex with of about 250 to 300. You can't always define what your vacuum needs to be, okay? So if you have shallowing of the anterior chamber at any point, then you need to reduce your vacuum and or increase the bottle height. You decide what the vacuum needs to be, right? Decrease the bottle height or increase the bottle height or reduce the vacuum to maintain your chamber. That should be your gold standard. Now, in this case, there was a rent in the beginning of the polar cataract, and it's a very soft nucleus. I just did a little vitrectomy in the center. Then I went in the IA cut mode, and watch, while doing a viscofluid exchange, I'm only using the aspiration mode. This is a 20 gauge cutter, which made it easier for me at that point to just merely aspirate that entire cortex. Now, you can afford to be in the IA cut mode after you've cleared all the vitreous, should there be any in between. I think this is just another important point that I would like to highlight. That is one of viscofluid exchange. Let me explain to you in this case. So you can see that there's a large rent. Because there's no vitreous disturbance, the surgeon goes in the epinucleus mode and aspirates the entire cortex. Now, at this point, if I just come out, the vitreous would have herniated. So instilling some viscoelastic before bringing the source of irrigation out of the eye always tends to compartmentalize the vitreous. And this is the last part of my talk. The importance of understanding why we use triamcin alone and how much to use. It always should be non-preserved. It's 40 milligram per ml. You take 0.4 milligram in 0.1 ml and still dilute it further. The important thing is to stain only the anterior vitreous, anterior disturbed vitreous. And when you're cutting the vitreous, you know, the funny thing is that every time you see that tricot floating around in the anterior vitreous, we wait for it to come. We think we need to sit and cut that vitreous as well, the vitreous or the tricot or whatever that is. So you limit how much you inject into the eye, because all you want to do is work in the anterior chamber. So even here, I've cut. I'm fairly certain that my vitrectomy is clear. But then there's that tendency, you know, there's more coming, there's more coming, there's more coming. You don't need to keep cutting just till all the tricot is then aspirated. So limit how much you really need to use. I hope that makes some sense here. So I'm just showing that here in this particular case. And once you're done with your vitrectomy, once more you do a viscofluid exchange, then get out of the eye, and then proceed with the next step of putting in the IOL. So here again you can see that the tear seems to be fairly well controlled. And finally, each of us needs to know what is the end point of a well-performed vitrectomy. You need to have all the prolapsed vitreous that is cut with the cutter facing you with the correct settings, a new cutter. Then the rest of the tags are hanging onto the incision. Those cuts need to be removed, those tags need to be removed, and the pupil should be round and central. Thank you very much for your hearing.
I now invite none other than Dr. Arup Chakrabarti, a doyen in the field of ophthalmology, to throw some light on how you would go about managing vitreous that is admixed with nuclear bits. What happens while you're in the middle of phaco and you hit the posterior capsule, and there's this alarming vitreous that has come and got mixed with the nucleus? How do we proceed? How do we take it from here? So, Dr. Arup Chakrabarti, the stage is yours.
How did I? You spoke 17, 18 minutes.
So at the outset, good afternoon, everybody. And thank you, Dr. Suvira, for giving me an opportunity for this program. You know, I had been doing this course for a very long time at the American Academy, AIOS, and then I thought, you know, more enterprising youngsters will take over the case. And Suvira has been doing this case so well for the last so many years. Thank you, Suvira, for making me a part of this.
Pleasure.
So PCD most of the time we think is an end of the road for the patient, is a death sentence for the patient's eye. But what I have always been maintaining, that if you manage a case properly, you know, take proper precautions, prior precautions, and when you have a complication, if you manage it well, post-op outcome should be no different from that of a routine uncomplicated case. So I'm going to show you a couple of videos. My setup is a private setup, so these are all private patients, and so we do the very best for these patients that are available with us. So that come to us for our care services. So this was actually an elderly male, hard cataract, Todicile was planned, and I used an anesthesia, peribulbar block for that patient. So rexis was usual, you know, more than 5 millimeters in size, and it is not a small rexis. That's what I want to tell you. Is hydrodissection was done extremely carefully, because in hard cataracts, if you do a very rapid hydrodissection, in a very robust hydrodissection, there is always a possibility of a posterior capsular blowout, and a pupillary snap can happen, which can manifest as pupillary snap. Is the video moving? Okay, right. So everything was okay, you know, till the hydrodissection it was okay. When a sculpting, no, this was the Goider S3 VIP machine. It cuts very extremely well, and everything is going on pretty well. All right, so far so good. I don't think I have done anything that would have compromised on the capsular bag or the posterior capsule. So usually these sort of cases, I take the Chang chopper. Apasami modifies it, you know, by giving a chopper tip which is 2.25 millimeters in length. So you start chopping in the periphery, gradually bring it to the center. I have learned a great deal on management of PCD and chopping from Dr. Abhay Vasavada. I think Shail is here. So, you know, this is a step-by-step chopping situ, right? This is an extremely useful technique. You don't have to be, you know, use your raw force to do this technique. It can be done very delicately. You don't have to divide the nucleus into two pieces at the same time. You know, go step by step. Just bring, you know, the chop lines, make them converge at the center, and remove a piece, and then you have more space in the capsular bag to perform the manipulations, all right? Because the nucleus, it's filling up the capsular bag. So you try to rotate it. If you are not very careful, you know, you may end up pushing it, and then it may stretch the zonules. And these zonules, usually in hard cataracts, are pretty weak, you know, compared to standard cataracts. At this stage, I realized something is amiss. You know, the nucleus didn't rotate well. Followability, the nucleus is not just coming to the phaco tip. So then I knew that something has gone wrong. So please remember that it is always better to err on the safer side than, you know, assume that everything is fine, you know, like an ostrich phenomena. So I knew that maybe some things are okay, but there may be a big PCD or zonular dialysis. So I immediately injected viscoat behind the nucleus. So this is the visco shield strategy. Subsequently, strategies have been mentioned in IR scaffold and all that. No, but I still stick to these strategies for various reasons. So adequate amount of viscoat has been injected behind the nucleus. Anterior vitreous face is protected, and the nucleus sort of floats around the viscoat. Very gradually, very slow maneuvers, lower the portal height, not too low. You have to maintain the anterior chamber, and then adjust the parameters. So there should not be a turbulence. And before you come out of the anterior chamber with the phaco handpiece, phaco tip, you inject OVD. When you inject OVD, make sure that you are in position 1 to 0, so that OVD doesn't reflux out of the capsule of the eye. Otherwise, it is a wastage of the expensive OVD. So now there's a huge PCD. You know, on the nasal side, if you see here, there's no PC. So I don't know whether it's a large peripheral PC then, or whether it is zonular dialysis, some kind of a dialysis of the capsule has taken place there. There's a small chunk of nucleus which is just sort of floating in the anterior vitreous, capsular, cellular components present in the periphery, fortunately. So I just assessed. It's always good to step back, watch the damage, and then plan out. It should not be panicky. There should not be in a knee-jerk response to whatever you do. Just relax. And then I decided that, okay, now I'm going to perform irrigation aspiration bimanual, which I normally do for cortex removal. Irrigation is kept farthest from the area of the PC dent, because if you take the irrigation close to here, invariably the fluid jets is going to impinge on the anterior vitreous face. It is going to wash out the viscoat. And so I cleared up as much of cortex as possible. I would not be really finicky about picking up the last cell and make the capsular bag absolutely cell free. No, little bit of periphery is okay. Peripheral cells are okay, because you don't want too much of beta. I'll come to it later. So now I changed my IL option, because here there's a large PC dent and you cannot keep toric IL here. Oh no, you cannot align it. So the leading haptic was, I forgot to see what I did. So the leading haptic was, I think, initially delivered in the posterior capsule behind the iris. All right. Then I was not sure whether the leading haptic is going through the PC dent. All right. There's always a possibility, because there's no PC there. Always a possibility that the leading haptic will go into the vitreous. So I got a little worried, and then brought the leading haptic out and kept it safely in the anterior chamber in front of the iris tissue, in front of the iris. And then trailing haptic was dialed in. All this manipulation should be performed with a formed anterior chamber. This is don't do too much of dialing movement, because when you dial, you have to make a lot of movements, and then lens comes to rest. And finally, by the time you have over rotated the lens, so this compression technique works really well. And then I try to do a capsular buttonholing of the optic. Though there's a rexis step, but the capsule was intact and the rexis was intact. So that was done. And whenever there's a PC dent, even if there's no vitreous disturbance, or I haven't done a vitrectomy, I would put a 10 nylon suture. Best correct vision obtained for this patient was 6.9 and 6, and patient had done extremely well. So what I would like to tell you is, PC dent is inevitable. It happens. Even if you have doing phaco for a long time, it happens. Only way to avoid it is by stopping surgery, or by not being very truthful when you from the podiums. So whenever you see a bizarre nucleus behavior, suddenly trembling, tilting, lack of followability, difficulty to rotate, funny reflexes coming in the peripheral areas, there is trouble. All right. So this is I call the power of positive pessimism. You always think that, okay, now I'm dealing with a PC dent, take all the precautions and make sure that you do a very safe surgery. So because early diagnosis is the key matter, it makes a difference. So you assume the worst, PC dent, or in this case or other cases, zonular dialysis. Please remember that you need not be miserly with the use of OVDs, because there have been cases where I have used 3-4 syringes of viscoat. So whenever you are managing a complex cases, your goal has to be whatever is required to give the best outcome to the patient has to be given. All the calculations about finances, particularly those of us in the private sector, should go out of the window. Later on, they can be adjusted, or you can take a plan accordingly, depending upon a lot of other factors. So use whatever is necessary to make the patient get a good outcome. Viscoshield strategy works extremely well. Always use bimanual irrigation aspiration, because though the irrigation is slower, the cortex aspiration is slower, but still it gives a much better control. In cases, as Dr. Suvira had mentioned, that vitreous staining is a good thing to do with 4% triamcinolone acetonide suspension. Before it came, we used to prepare Kenalog, which had a preservative. We used to dilute it every day to prepare, keep it upright, so that the suspension settles down, discard the solute. So that has, once Orolab came up with this molecule, it has become very easy for us to manage. And never keep a single piece hydrophobic acrylic lens in the sulcus, even a hydrophilic acrylic lens in the sulcus. These lenses are not designed to go into the sulcus. These lenses are designed to be kept in the bag. So if you keep these 3-piece lenses in the sulcus, it is better to obtain an optic capture, as I mentioned earlier. And these patients are more prone for post-op sequelae. So be very vigilant. Post-operatively, do we have time or?
think you could take a minute more. Would you like a minute or two more?
2 minutes more.
I guess so, yeah.
Okay, okay. So I'll skip the videos. So what I'd like to tell you is now if you're not using you're not using intracameral antibiotics, now please use intracameral antibiotics for PCRN situations without vitrectomy, because studies have conclusively shown that massive studies at Aravind that incidence of post-op endophthalmitis is much higher in patients where posterior capsule has been compromised or vitreous has been disturbed. You have performed a vitrectomy, so that has to be done, and I have already discussed. So post-op counseling has to be absolutely meticulous. You have to be brutally frank with the patient that there has been a problem. Patient would have been attuned to this happening preoperatively, but then you have to tell the patient, yes, we had a problem. I have a friend who says that we did little bit of vitreous modification. We had to do a little bit of vitreous modification. Whatever way you put it doesn't matter, but you tell the patient that there has been issue, so we need to keep you under long-term follow-up. Potential complications include recurrent uveitis or recalcitrant uveitis, CME, glaucoma. These patients can develop retinal tear detachment. So if they're coming from peripheral areas, just 1 minute, they may not be able to come to me immediately, so they see an ophthalmologist who does an indirect ophthalmoscopy, and these cases are more prone for eye decentration and dislocation. Steroids may have to be used for a longer period of time, or NSAIDs may have to be used for a longer period of time. We are not very finicky or not very particular about removing the last molecule of OVD, because if you try to do that, too much of good is better. So if you try to remove the entire visco, you may end up shallowing the anterior chamber. The more vitreous may come, so you have to do the whole cycle all over again. So sometimes we do leave behind a little bit of OVD, dispersive OVD visco is pretty okay behind the optic, and we assume that we assume the patient is going to develop ocular hypertension, and that can be medically managed for a few days. Sometimes the patient comes next day with corneal bleeding, high pressure. We resist the temptation of doing aqueous tap. So normally we just release some aqueous from the anterior chamber, then it settles down. So that should not be done, because moment you get a shallowing of the anterior chamber, there's a possibility of vitreous coming forward and getting stuck to the paracentesis, or sometimes just it envelops the intraocular lens. So thank you very much for your kind attention.
Thank you, Dr. Arup. It was a brilliant presentation, very complete. I'd like to now invite Dr. Vidisha Mahapatra. She will present 2 talks. Again, a posterior capsular rupture, along with during nucleus management, and a second talk would be whether or not premium IOLs can be placed in a patient who has had a PC rent. Thank you. Bye-bye. Thank you.
Good evening, one and all. I shall be presenting on behalf of Dr. Sudeep Das sir, who could not be present due to some issues. So, management of PCR. These will be basically surgical videos. So, in this first case, what
Talk
we see.
Talk a little louder. Come closer to
Okay.
them.
In the first case, what we see, phacoemulsification is completed, epinucleus removal. At the end of that stage, the surgeon notices a PCR and it is converted into a posterior capsular rhexis. There is no VL and IOL is injected into the bag. So the important thing was the PCR was converted into posterior capsular rhexis, and then after that we can place the lens in the bag. And then the remaining part of epinucleus is aspirated. In the second case, it is a posterior polar cataract, bit on the harder side, maybe stage 3. So surgery otherwise goes well. The nucleus is emulsified well. So the nucleus is completely emulsified, and after that what is noticed is there is a PC dehiscence there.
Come
So
closer to the mic.
yes,
We
so there
can't-
is a PC dehiscence now. So the thing is, inject visco and then come out. We should not come out, bring out the probe without injecting visco. So again, till now there is no vitreous loss. The epinucleus is brought out and it is emulsified. So from the other hand, again visco goes in. Vortex is aspirated. And again viscoelastics injected. And the lens is dialed into the bag. This is the next case. It is again a posterior polar cataract, but it is a softer one. So the endonucleus is emulsified. While removing the epinucleus sheet, there again we notice there is a PC dehiscence behind. Viscoelastics are injected. Remaining epinuclear sheet is aspirated. The aspiration is being done within the left hand. There is viscoelastics injected continuously, and then the PC rent is converted into a posterior capsular axis. So there is vitreous now. Anterior vitrectomy is done after completing the posterior capsular axis. And then goes the IOL into the bag. This was a hard cataract. During the last piece emulsification, the surgeon notices a PCR behind. So under continuous irrigation of viscoat, the emulsification is being carried out. And then IOL is injected into the bag. This is a case of a black cataract where at this stage a PCR is noted, and then the surgeon uses a scaffold technique of completing the rest of the phacoemulsification. It's a bit risky thing, which I think maybe very experienced surgeons can only take the risk of this. So a 3-piece foldable lens is injected, is kept above the iris. In this step, the main thing will be protecting the endothelium. Of course, we have to use profuse viscoelastics and then complete the emulsifying rest of the pieces. And after completion of emulsification, the IOL will be dialed into the sulcus. It's a 3-piece foldable IOL going into the sulcus. So the points to be noted are: watch out for early signs of PCR that can be the difference between an excellence and a disaster. So the signs of seeing folds in the PC, any unusual movement of any nuclear bit, sudden failure of holdability or followability, any slight change in anterior chamber depth, and one can always train oneself to feel the pop of the posterior capsule giving away. Always keep good dispersive visco OVDs ready at all the times. Master anterior vitrectomy and posterior capsular rhexis, and then choose the appropriate IOL for implantation after PCR. Thank you.
Dr. Bidisha will now. I think Minu, are you good to go straight away?
Yes, ma'am.
Okay, then I'll let her finish. Dr. Bidisha, on behalf of Dr. Sudeep, will now present her second paper. Can premium IOLs be implanted in patients with a PCR? Just stand a little closer to the mic, dear.
Okay. Yes, ma'am. Can premium IOL implantation be done following a PC run? Any intraocular lens of choice can be implanted in the bag if the posterior capsular rent is converted into a posterior capsular rhexis and anterior vitrectomy, if necessary, has been done. If the PCR is large with insufficient PC support, implant a 3-piece foldable intraocular lens in the sulcus with optic capture whenever possible. Reverse optic capture of a single piece foldable IOLs need exceptional skills, and there is high possibility of the IOL dropping while doing this. Reverse optic capture of 3-piece IOL is easier and safer. So choose an appropriate monofocal IOL over the promised premium IOL if necessary. So this is a video of a hard cataract being emulsified. The surgeon is polishing the PC, and it was actually a hard cataract with a posterior polar component. And the last stage, what he sees is a peripheral PCR there. So there is no VL, and the PCR is converted into a posterior capsular rhexis. And it's a multifocal IOL going into the bag. So the point was, in a posterior polar cataract, either we should not do a PC polishing or should be very cautious while doing it. Next is a brown cataract in which PCR happens during irrigation aspiration. It was a case of toric intraocular lens implantation. So it's a brown cataract, you can see it. Emulsification goes well, but during irrigation aspiration, there is a PCR. With vitreous loss. So no, there was no vitreous loss actually. So as soon as he notices a PCR, injects viscoelastics so that it doesn't extend, and then since there was no VL also, we can implant the IOL into the bag. This is a case of posterior polar cataract. So after the nucleus emulsification, PC dehiscence is noted, viscoelastics are injected, and the PC dent is large here. Anterior vitrectomy is being performed. After a thorough anterior vitrectomy, the remaining cortical matter is aspirated. And a 3-piece foldable multifocal IOL was placed into the sulcus. So the take home point is, long-term outcome is more important than short-term economical goals. Choose the option that you would choose for your own eye. Thank you.
Thank you very much.
Thank you, ma'am.
Thank you, Dr. Vinisha. I'd like to now invite Dr. Minumanthan, a very senior consultant, a great surgeon, and a good friend. He's going to now discuss with us about how to manage cases of posterior capsular rupture, which occur either during irrigation aspiration or IOL implantation.
Good afternoon, ladies and gentlemen. Thank you, Dr. Suvira, for this opportunity. According to me, during IA, I get maximum posterior capsular rupture. How many of you feel that you will get similar posterior capsular rupture during IA? One is because I am very relaxed. Nucleus is gone, so no nucleus drop, so I will relax. Second thing is, there is gross mismatch between irrigation and aspiration, especially in bimanual IAs. And when we do large volumes, we get different types of irrigation aspiration systems. We don't know which is 22, which is 23, which is 20. So there is mismatch and there is surge. So these are the ones which you should make sure. And then IOL implantation again, especially when you are implanting Indian-made IOLs. And I have nothing against India or Indian-made IOLs, but then when you have inconsistent structure of cartridges, injection nozzles, then you end up in problems. And so let's go in detail into this. Managing no financial interest in having PC rent in during IA. What PC rent during IA? So see, this is IA. Looks so inviting and nice, you know. So generally nowadays I put viscoelastic before doing it. That is, once my resident is asking, why do you put viscoelastic unnecessarily? I said, anyway, nurse is waiting. She is changing the handpiece. It is taking time. Why should I wait? I'll just put some viscoelastic and look at it and all. But anyway, many times the chamber shallows. when you are getting. So I don't want the chamber to shallow, one thing. Second thing is, if the bag is inflated, you can approach the most difficult area. Especially I am trained in coaxial IA, so I use coaxial IA. There are many advantages for that, although that the other one is also fine. I have nothing against it. So I go sub-incisional first. When I go sub-incisional first, when the bag is full, this is not such a one, but then generally I do that. So when the bag is full, the PC is very far back. I can firmly turn my tip down facing the PC. It doesn't aspirate the PC much. And again, as Shale can realize, they had a video showing that it's a clean sweep. You should sweep it from the equator, bring it to the center. So I am aspirating from the equator. That's not a great idea. Now I am aspirating from the PC, and see, I'm going and nudging at the PC now. I just held the PC, if you had seen very carefully. Somebody is looking very surprised. Please look again. I caught the PC just like that there. So if you do not sweep each layer of cortex and finish off from the posterior capsule, you will have pieces sticking onto the posterior capsule, and you will have to face the tip down and aspirate and catch. And now I do this flushing. Flushing is relatively safe for me now, rather than going in the whatever aspiration mode of 10 or 20. Still, many capsules of old people, the zonules are not very strong, and the capsules are low lax. Even 10 it may catch, and the vacuum may pull, and you'll see folds radiating. But if they are very taut ones, young ones, immature ones, nothing will happen even if you have a 20 vacuum and sweep over the capsule. But this one seems to be very, even if I touch the capsule with these kind of round tipped cannulae, nothing happens. So flushing will help me get all these fibers out. I like clean capsules. So once this is done, we try to introduce the IOL. See, I have done nothing wrong. IOL is going in clean. The bag was fine. And just after implanting very nicely and trying to aspirate the cortex, I aspirate from behind also. See the viscoelastic. Now I see two lines on the capsule there. So if you notice very carefully, why have you switched on this light so bright? Yeah,
That's
think
the
this
problem.
is also
All these
can't
ones
switch
have
it off.
this.
See those two lines there. So people can consider that as a posterior capsule, but this is a strand of cortex. So you may get misled by folds, but folds which do not change their shape even while slight manipulation of the IOL should be considered as posterior capsule. But otherwise, if you manipulate a little and they are changing shape and budging and moving and all those, then they are cortex only. So don't be scared of all the folds, but always look out for folds on the capsule. See, like this. So if you have a capsule held like this, now you can just release your foot pedal. But if you release the foot pedal, sometimes it doesn't go off. Then you should know where the reflex button is. So reflex button, then only we will remember that there is something called reflex, and you will ask nurse, where is the reflex button? Up, left, or right, or where should I, what should I? So please use and make sure that it is always at one position. If you are using multiple rooms, multiple machines, you don't know which machine you are using, somebody else's setting will be there. So always initially itself, just make sure where the reflex button is. So that is in a good enough. See, that's what I just wanted to show, that once you have held, even if you leave the foot pedal off, now it is fully off, still it is not going off. So now you can see at bottom of this one, the reflex button. So the reflex button, if you hit, it will go off. The more you pull and the vacuum will generate and pull, then only it will break. Most of the capsules, just like that, when held, do not break. So this is a posterior capsule being nudged, and whatever you do to pull out the small fibers, you get a small opening there, and you get scared and withdraw the whole thing. So then chamber shallows, the opening becomes larger here, and it becomes full from one end to the other. So whenever you get an opening, do not be scared. Don't irrigate, don't take out the irrigation, put in viscoelastic, form the chamber, and then only take out. So like that, I did it for this case. There was a small opening here, if you see in here, small opening, very nice. So I just put viscoelastic, and so many air bubbles came from viscoelastics. I hate air bubbles, so I thought we should take all the air bubbles out and put more viscoelastic. So I'm hyperinflating, and see what happened. It opened up into a full thing. So when there are pointed edges, hyperinflating and lowering, shallowing the chamber, both can increase the size of a posterior capsule rupture. So don't overinflate, thinking that your visco is a great friend, then you keep on putting more, it will be nice and all. So if you dislike air bubbles, take them out so that there is some leakage also. If you put sodium hyaluronate right into the posterior capsule, it can push on the posterior capsule drastically. So that is why, with the help of Epsilon company, I told them to make me bimanual IA, which gives very good irrigation, and it is slightly only larger, and you should know the size of your zone. With the 1.1 incision, it's a snug fit. It's a snug fit. It doesn't leak. And the other one, every bimanual eye, if you take and then compare with your coaxial IA, the aspirating tip will be larger. I don't know why they make like that. And I told them to make it exactly 0.3, which is the size of your coaxial. So coaxial, that aspiration being larger makes the big difference, and the irrigating and the paracentesis ports leaking makes a big difference. Here, see, no change in chamber, no chamber fluctuation. So if no chamber fluctuation, everything is cool. Chamber fluctuation is the one which makes you scared, and then you may catch the capsule when you are going close to it. And irrigation, when I tried with this gives you, I got me around 75% of a coaxial irrigation. It will never come any close to the coaxial irrigation, but then 75% of the previous ones which I had, which were 20 gauge and all, they were giving 45, 60, maximum was 60, which I could get. So that irrigation may not be enough when you're aspirating very well, especially with larger aspirating ports. I have no financial interest in this, and I don't know whether they're making more of this. They gave me few, and after that I have not bought, and I don't know whether they're making or whether they have a number for that. So implanting an IOL, some IOLs will fly like this, and then it may hit any part of your capsule. See, a wrong method of 3-piece IOL being loaded with the haptic folded away from you. If the haptic folded towards the right, it will swing along, and while injecting, if you lose a lot of viscoelastic, then it will tear onto the posterior capsule. And I many times shoot these lenses very effectively into the bag, into the anterior chamber. See, this is all because of faulty injector tips. These are metal ones which can be reused multiple times, and they become straighter. They have to be at an angle so that it will slide along the optic. When it becomes straight, it will go over the optic, and then it will form a bottleneck. You can see it here. It is overriding the optic here. So then once it reaches a smaller, shortest width, you will need to generate a lot of force, and once it crosses that force will force the lens to fly into this one. So I catapulted the lens into the bag, and it is sticking there. It's not gone anywhere. So I thought I'll pull it back. Somehow there will be a piece around there in the periphery. Pupil is not that dilated. So just retract the haptics and place it away from the area where you think there is either a dialysis or a rent. But when this was in the PC and there is a rent. So I just retract and see. And using another thing, just curiosity, retracting and seeing. Although it is going out, we have some more time, no?
Yes.
Yeah.
Yes,
So
we do.
it is going out, and I go there and aspirate. Such a silly idiot I am, and I get vitreous. There was no need to go anywhere near that and aspirate, just for the sake of finding out what is happening. And now see the small piece which is there on top. And there unnecessarily I went and aspirated to take out all the viscoelastic and all. So don't be adventurous and too much nosy about all these things. Something wrong happens. If nothing is, you can visibly nothing is wrong, leave it and place the lens stably in another location and let some visco be there. Nothing will happen. I had to do finally a vitrectomy in this. So please learn from these silly mistakes which me at this age also make. So this is a mature cataract, a full rhexis. It is completely there. Just to make sure that the rhexis is completely there, I'm just showing you that the rhexis is complete. I finished the phaco, fill up the chamber, aspirate everything. Pupil comes down a little bit, and the chamber is not fully formed. This is a problem here. So this time it doesn't fly in, but then the bent tip goes little more into the bag, and now I see a fold here. See here, it was nothing wrong. Just the lens into the bag and just a rotation. So I just failed to, I deny that there is a piece around here. There could be some fold, there is cortex there, but still I realize that fold is not changing location, not changing position. It is extending from one end to the other, and it is an inferior piece around. So I cannot leave a large piece around like that with the lens haptic anywhere close to it, and it will decenter for sure sometimes, mostly, and especially because it is inferior. So I have to explant this. I have to dial it out of the bag and place. Do you want to see that? Place an IOL. No time, no, to show all those. So explant it. Place another IOL. Cut it. I should be showing that because that's not a that's not a bad thing to show.
Please do.
So yeah. So where is that? So this lens is dialed out into the anterior chamber, and a fresh another IOL, 3-piece IOL is placed into the sulcus under this lens, and that is all done with sodium hyaluronate filling up everything. And then this IOL is oriented in such a way that through the paracentesis I can hold the optic, and then I use a long tipped Vanna scissors which work for me in all lenses. I extend it 2.8 to a 3 to 3.2 so that it comes out very easily. There's no point in struggling to pull out these lenses, half of this lens through a small opening. Nothing. You're not going to gain anything. It is going to stretch the incision, and it is going to damage your incision. So this cutter is kept separately and not used in a regular case. It is kept separately and asked for when these kind of things happen. And there are fancy cutters, costly ones there, they do very well. But still, this also does very well for me. But it has to be a longer one, and do not use it for other purposes and make it blunt. It is made by Appasamy. I don't have any financial interests, I can tell you also. So you can also go and buy. So after this, this is in the sulcus, and if because there is a mature cataract, the rexus is slightly larger than 5.5, and anything less than 5 only an effective capture can happen, optic capture. This is optic captured. It is less than 5.5, but then otherwise, if it is more than 5.5, it won't get actively captured. It has to be less than 5. So this is another PC rent. Vitrectomy, I think in the previous talks they would have all talked about vitrectomy. I don't want to talk about vitrectomy. At the end, if you cannot see, I will put triamcinolone, because triamcinolone, I have seen it being repeatedly put and all those. It after a vitrectomy, it will just flow into the vitreous cavity, won't come out. And if you do not dilute it very much, it is going to stay there and cause intractable glaucoma and all those. So the retina people, they will curse you for putting all these. And after putting an IOL, if you want, you can construct a pupil and then put on top of it and see whether there's whatever this comes. I will not stop for the next 2 minutes more, 2 more minutes. So then this IOL goes into the sulcus. So the IOL goes into the sulcus, and here the rexus is small enough. So watch carefully. I am going this in the sulcus, and I am going with a vitrector because lot of visco has gone into the anterior vitreous space. I cannot just like that leave it there. That can again cause definite IOP rise. So yeah, although it is sodium hyaluronate, HPMC, sure, no. Don't take HPMC after you see a PC rent. Throw that down. Take only sodium hyaluronate. And then that comes out. When that is aspirated, some vitreous will also come. So use your vitrectomy probe. That will be the best thing to get everything out, most of it out, because lot of visco vitreous, if you have cut, there is space for some visco also to be there. After this, you can manipulate with your second instrument, because some cases I have captured and there is a lot of visco behind, and it causes a lot of pressure inside, and you can't take it out also. So you can just nudge it out. See the second one in one part of the optic going under the rexus margin, and the other part was also nudged under the rexus margin. So this is locked for good. You don't have to change the IOL power. You don't have to be scared about decentration later. And the good thing is that this patient will not get a PCO. You don't have to yak this. But then after this, doing a vitrectomy, please see the periphery of the retina and then send them to retina clinic, because you would have aspirated. See, this is the last video of my trainee getting a PC rent in the nasal part, big PC rent. Rexus is intact. So then we will start shaking, adrenaline problem, and then the decision making, everything is haywire. So the single piece IOL goes inside. It goes directly into the PC rent. I told her, stop, you get a forceps and hold. Took a Sinski. And with the Sinski trying to manipulate, instead of that, hitting the IOL, and IOL is keeping on going. So after some time, again she is going out and getting, she is just a she. So taking it out, and then it just drops. So it doesn't just like that drop. It will give you some minutes or seconds. By the time you should act. Before that it doesn't just fall. But remember, at the right time, take the right instrument and catch it, and bring it somewhere above the rim. So if you keep watching it, it will slowly fall into the vitreous in front of you. So training time, it is okay. But then once you are doing it alone, then it's very difficult to go and tell patient that you had very little support behind, and it went further behind, and somebody else has to come from behind and take it and all. Then they will tell you, Then they will tell you, why didn't you tell me all these things? You didn't tell me. You said nice cataract, you will do good cataract surgery and all those things. So very difficult to explain to patients when they have to be shifted, because when you have a big institute, they just have to be shifted from one OT to the other and get the VR person to get it out. But then other centers, it is difficult. Even if you shift, you can tell suddenly there is a current cut, or a machine has gone conked, some sound you make, quang quang sounds, or so now we'll go to a different room and do the rest of the surgery. Don't worry and all. So that way you may escape. Thank you very much.
Thank you, Dr. Minu. It was an excellent presentation. I'd like to now call on my colleague, Dr. Sarvesh Tiwari, who will speak to us about demystifying pars plana anterior vitrectomy for us anterior segment surgeons, and finish by talking briefly about post-op patient care. Dr. Sarvesh.
Thank you, Dr. Savira, for the intro. So let me first clarify, I'm a posterior segment surgeon. So after all that enlightening talk which we had by various speakers, as Dr. Das pointed out, what to do if you have a small piece going behind. So I'm going to give the tricks for which you don't have to refer the patient to a VR surgeon, and you can somehow manage small complications on your own. So going ahead with my talk, no financial interest. So as we all know that modern day 3-port vitrectomy was invented by O'Malley and Hayes in the year 1975. It's a closed control system for accessing the posterior segment. Anterior vitrectomy is particularly important in managing complications of cataract surgery like PC rent and vitreous prolapse. So before we go ahead, in which cases do you think you will anticipate a vitreous loss? As most of you are anterior segment surgeons, you are well versed with these cases. Cases like posterior segment, posterior capsular cataract, small pupil, zonal dialysis, traumatic ones, those who had a history of VR surgery in the past, and patient factors like uncooperative, anxious patients, patients with spine problems who are unable to lie supine, and those who are having frontal bossing or deep sockets. These are the cases which are more prone to PC rents and vitreous prolapse. So as we all know that vitreous prolapse comes with its own set of problems like CME, IOL decentration, endophthalmitis, and endothelial decompensation in the long run. These can be efficiently prevented by a good thorough anterior or posterior vitrectomy. So why am I advocating the pars plana approach? It's not because I'm a posterior segment surgeon. It's because of these particular points which I'm going to highlight. Going by the pars plana, it prevents a vitreous drag posteriorly, and there's a lesser vitreoretinal traction. This ensures an efficient removal of the anterior hyaloid. It also ensures a thorough cleaning of the cortical debris that has migrated posteriorly in case of small rents. And it also protects the anterior capsule remnant, which gives you a sufficient sulcus to place a 3-piece IOL inside it. It also prevents vitreous incarceration in the corneal wound, prevents iris trauma as there is repeated shallowing of the AC. It prevents corneal endothelial damage in the long run. And since it's a closed chamber, there are lesser IOP fluctuations, which lessens the risk of suprachoroidal hemorrhage, which can happen due to sudden globe decompression. So through a schematic diagram, I'm trying to just show you the two ways when you approach it through the anterior approach through the limbus. As you can see, when you're trying to eat the vitreous, you are inadvertently sucking at the vitreous, and in case your cutter is not a new one, or you have not used it for a long while, you are a good surgeon, and now suddenly you have to use it. Many times the cutters are not that efficient when kept for a long time. In this case, the suction is more than the cutting. This will cause an inadvertent traction at the posterior vitreous, which will cause more of the vitreous to migrate into the anterior chamber. However, if you go by the pars plana approach, as you can see, you are approaching the vitreous from the backside. In fact, you are reducing the vitreous which has prolapsed in the AC. As you can see in the first case also, if there is a lot of pull at the vitreous, it can cause a traction somewhere else and cause an inadvertent retinal tear. So in case you're using a pars plana approach for anterior vitrectomy, what are the requirements? You require a trocar cannula infusion set, infusion cannula in case you want to go through the pars plana, or you can use your irrigation through your side port also, a vitreous cutter, an illumination source in case you use a pars plana approach, and a surgical microscope, of course. So this is the pars. This type of set is freely available in the market. You can see that's the long infusion port which can be connected to a IV infusion set, and those are the 3 pars plana trocar cannula set. If you are choosing the pars plana approach, it is best to use a 25 gauge system. This is because unlike the anterior chamber, when you're going through the AC, you have your side ports which can be easily hydrated at the end of the surgery. However, the side ports, if you are using 23 or say 20, you need to suture them. That won't be very easy in case you have not cut the conjunctiva, means you have not done the peritomy. In such cases, it is best to use a 25 gauge because they are sutureless. So you can just, I'll show you, you can just swipe it up with a bud and they close on their own. So the salient points while doing this procedure, you have to avoid the 3 and 9 o'clock meridians for making the ports, to avoid the long posterior ciliary arteries and nerves. You have to freely use triamcinolone to stain the vitreous and insert the trocar 3.5 millimeter posterior to the limbus. The cut rate has to be approximately 1200 cuts per minute, suction around 100 millimeter of mercury, and the bottle height should not be too high. Always remember that whenever you are coming out, the cutter should be always on and the cutter mouth should be always superior. So this is just a small video to show you how the procedures perform. In this case, there was a PC rent. The anterior segment surgeon had already placed the IOL, and as you can see, a small cortical debris floating behind the IOL in the anterior vitreous. So here, first you have to make is the infusion port in the infratemporal quadrant. So you have to choose the site 3.5 millimeter from the limbus. Hold the conjunctiva slightly retracted, and you have to go tangential initially and then perpendicular to the globe. Doing this is a biplanar incision which creates a very nice watertight port which doesn't leak later on. Before you place the infusion line, always get rid of the air bubbles by starting the infusion and then fix it to the infusion cannula. I'll just fasten the video. Make your other ports. So in this case, I'm using the illumination light pipe separately. You can use the microscope illumination itself if you're going through the anterior chamber for the irrigation. So here you can see that cortical chunk which is in the anterior vitreous just behind the IOL. So here my light pipe gives me an additional hand to handle that in the anterior vitreous, preventing it from falling behind, and with a very gentle suction you have to go on cutting and aspirating it. I'll be just so after this is done, I'll just show you how to remove it. Yeah, so this is the last port. As you can see, you have to come out in the direction in which you had entered. As you can see, there you can see an air bubble behind. I would suggest that if you're going through the pars plana, it is best to inject at least 0.3 cc of air through one of the ports. This air bubble makes your wound watertight, so it doesn't leak because the air goes and opposes all the 3 ports from the pars plana. So this is the pre-op and the post-op picture of the same. So once you have dealt with such a case, how to take care of these patients post-operatively? So I would divide this into 3 stages. First, on first post-op day, what you should observe in such patients, you have to see for whether there is any vitreous in the AC. Has there been a vitreous touch? Is there a vitreous wick? Or is there vitreous coming in the AC causing a pupillary block? If you find any of these, the management is obviously anterior vitrectomy for vitreous in AC and or a ND-YAG laser hyalotomy at a later stage. You have to also look for a dilated peripheral retina to see for inadvertent breaks or tears or dialysis in the peripheral retina. Look for any dislocated lens or cortical fragments in the vitreous cavity, and look for IOL stability, whether it's well centered or not. In the first, after 1 week, where the patient follows up, look for the IOP, because you can get late onset ocular hypertension, especially when lots of viscoelastic has been left behind. And look for the corneal endothelium, whether it's patient is having an early corneal decomposition or something. When the patient comes to after 1 month, you have to look for things like vitreomacular traction. Obviously, this will not be visible to you clinically, but if you see there isn't a good vision improvement 1 month post surgery, then you should get a OCT done. In that case, you may find vitreomacular traction due to the vitreous in the AC. You can find a cystoid macular edema also, and you can find a retinal detachment also. So in such cases, as we all know, start topical steroids. If the patient has already been on steroids, don't taper it fast. Topical NSAIDs to be continued for 4 weeks at least. Beyond this, in non-responsive cases, be free to use subtenance triamcinolone in the strength of 40 milligrams per ml. And if the CME still persists identify the cause. There has to be a cause for this and treat the cause. Thank you.
Thank you, Dr. Sarvesh. It was very good. Thank you so much. Are there any questions that anybody has for any of the panelists that are still here? I guess then we could draw this course to an end. Thank you very much for coming and attending, and I hope it was useful to you.
There's one faculty talk in the course.
In our course?
Yeah.
Oh,
The AIS program. Sorry.
oh, I'm sorry.
I'm sorry.
Sharon, can I just speak with you a minute?
Yeah. Please go ahead. Yeah.
Could you take a flight? I will introduce you.
Please go ahead. That's absolutely. Was there something you should be saying?
Let me just invite you. I don't. Yes, they haven't given it yet. I'm sorry, this is something I wasn't aware of. I now like to invite Dr. Shair Vasavda, who's going to give his talk on mini monovision with extended vision IOLs for the Indian population.
Thank you very much, and it's a sort of misfit in this course. Excellent course. I was there right from start to end, and I think all of us have gained so many tips that will be very useful when we operate Monday onwards. Yeah. Sorry. क्या हुआ? अच्छा, it's- No problem. वरना ये अभी हो गया था. ये सारे कोर्सेज में यही चला. ठीक है, आपका कनेक्ट कर लीजिए.
Dr. Anand is left. Anand is here. But I was wondering how to. Yeah. Yeah, okay. But I was wondering how you could retain that cortex there without dropping down while cutting. Because invariably for me, it will drop for sure.
That depends upon whether there is a posterior vitreous liquefaction. This space, patient didn't have a PVD, so that vitreous itself was acted like a scaffold. So you would have seen it was going behind, but it didn't fall down.
Mm-hmm.
यहाँ वो change हो ही जा रहा है.
That's good, because if you do more of vitrectomy, then the chances are that this will just fall off. And you are using a new point is that the trocar cannula has to be new, especially when you have an intraoperative PC rent and you are using a cannula, a trocar. If they give you the older reused ones, it is very difficult to go into a soft eye with this.
हाँ ठीक है ठीक है ठीक. So mini monovision is a strategy that is being propagated particularly for the several newer kind of EDOF IOLs, the non-diffractive ones, to provide a better range of intermediate or near vision to the patients, as these lenses are predominantly designed for distance and intermediate vision. So we did a prospective study to compare the outcomes following bilateral implantation of the Vivity IOL when we targeted bilateral emetropia versus mini monovision. It was a prospective randomized single center trial where 140 eyes of 70 patients were in each group were divided into one group which had bilateral emetropia, and in the second group patients were chosen to have their second eye with a target close to minus 0.5 but not more than minus 0.75 in the non-dominant eye. What we looked to achieve or to study was the binocular unaided near visual acuity at 40 centimeters after the second eye surgery. This was our primary outcome measure. And the secondary outcome measures were binocular unaided distance as well as near, and corrected as well as uncorrected intermediate and near acuity, along with the mesopic contrast sensitivity, because we've also wanted to see how affecting monovision would make the contrast go. The demographic parameters were equal across all groups, across both the groups. What we did find was surprisingly that the unaided distance vision was not significantly different between the two groups. So the difference in the distance visual acuity was not great. However, the spherical equivalent, of course, because one eye was targeted for myopia, this difference in the spherical equivalent was significant between the two groups. But unaided distance visual acuity did not deteriorate in the mini monovision group. When we looked at the intermediate vision was comparable for across both groups, which means that the mini monovision group as well as the emetropia group had similar intermediate vision. So the intermediate vision was not improved more by doing a mini monovision. The near add also the near for 66 centimeters, that is for intermediate, did not differ between the two groups. When we looked at the near visual acuity, the mini monovision group did better. So the difference in the unaided visual acuity was significantly better in the mini monovision group, and the reading add that was required was significantly less in the mini monovision group compared to the emetropia group, as you can see here. However, both groups did require an add for good comfortable near vision reading. So mini monovision required lesser add, but it's not as if they did not require any add for near. When we compared the contrast sensitivity across different cycles, the emetropia and the mini monovision group did equal, both in the photopic as well as in the mesopic contrast with glare, testing with glare, which is of tremendous importance. Both of these groups did equal across all different cycles. We also did a quality of vision questionnaire assessment, which has been validated in previous publications, and none of the patients reported any bothersome glare halos even in the mini monovision group, keeping in mind that they have slight ametropia between the two eyes. So I think it provides excellent unaided distance visual acuity in both groups. Targeting the other eye for about close to minus 0.5 improves had a positive impact on the near vision without affecting the distance vision. But once again, for counseling point of view, it doesn't mean that they won't require reading ads. EDOFs are still predominantly for distance and near vision acuity. And this has recently been corroborated in literature, where they've also shown that targeting a little myopia doesn't affect the distance vision but improves the near vision somewhat. Just a case to highlight that, this was a 64-year-old lady. She's now at home, actively do a stock market trading and analysis on her desktop. Children stay abroad, very well to do, but stay abroad, and husband is almost bedridden with chronic ailments, so doesn't drive. So she is the one who's running the home and managing all the finances and takes her husband to clinics, so on and so forth. She had cortical cataracts, hypermetropia with astigmatism and presbyopia. She was keen on spectacle independence but did not want any compromise in the quality of vision, because she is the main person running everything. So this was while we planning the first eye, what we chose was a 24 diopter T3 for her, and fortunately things went off well. We talked to her that let's do one eye, let's see the refractive outcome, and let's see if we can do a little myopia in the other eye at that point of time. The surgery went off well. As you can see, these are the zones, the non-diffractive zones that are there, which actually stretch and give the improved intermediate and somewhat near vision, and these are the toric marks to show the toric component. She did very well post-operatively after one eye cataract surgery with reasonably good intermediate and near vision. So now when we did the second eye, normally we would have chosen 22 as our first choice of IOL for targeting emetropia, but for the second eye we went one step ahead and we did a 22.5. So we are targeting a little myopia, but not to the tune of say 0.75 or 1 or so. So having done a 22.5 in the other eye, she did very well both for intermediate as well as for near. And she tells us that she is able to do most of her activities without glasses. Of course, for reading very fine print, particularly the names and the expiry dates on her husband's medicines, she does require a reading ad of the tune of 1 to 1.25 diopters. So I think the implications of this study are that surgeons may consider targeting a slight mini monovision in these kinds of non-diffractive extended depth of focus lens to improve the range of near visual performance. Once again, however, not to say that they won't require reading ads or they can be spectacle independent for sure. Thank you so much for the patient listening.
Shale, one question is, we have also seen this with the VVT, but when you tell them that you will be 6-9 parts, will you tell them that, or because binocularly it may not be less than 6 parts or whatever,
Yes.
but then 6-9 parts, will you have to tell them, or
Yeah, we generally always tell them that we are going to try, particularly when we have told them pre-operatively before the first eye, that if the first eye ends up on as how we expect with distance great vision, we may consider improving your near vision a little bit in the other eye. There will be, when you compare each eyes, you may find your distance vision to be slightly better in one eye and near vision to be slightly better in the other eye. So we do tell them about
yeah,
it.
but this is all the same thing we do tell, but how often do they accept that when they think that binocularly they cannot see the same in both the eyes, they will ask, first thing they will ask is how we will be driving.
Correct.
Will I be able to see at the distance similarly and all those?
Correct.
They're convinced by
So,
this.
so to be honest, it's not. I mean, we don't offer mini monovision to each and everyone whom we do VVT. First plan is always target emetropia. But if after first eye we find they are good, they are happy, they seem to be the accepting time, we talk to them about it and we do consider it.
Yeah, because this is a very costly one, much costlier than the
Correct,
panoptics,
correct.
and they placed it very high. So their expectation about that will be very high when they
Absolutely.
pay so much.
Absolutely,
But then
sir.
this, after the both eyes are done, people who agree to this are all very happy.
Correct, sir.
They are all very happy with. Then mostly they don't use glasses, although they
Correct,
carry glasses. Mostly they don't use glasses. So
Mostly they
I'm very happy with these bino, but there are fewer patients accepting it because of the
Yeah,
exorbitantly high
Very true,
pricing
sir.
this they have done for this. But-
Absolutely, sir. 100% agree.
and how do you decide which is the dominant eye?
Sir, to be honest, it's more for theory than more for study purposes. When we do, we typically use the manual triangle test, which has been done by. But in a routine clinical case scenario, we just operate the eye which has more cataract.
More
first.
cataract. So they also will say do the worst eye.
Yeah.
If you tell that
Correct,
either
correct.
other eye is the dominant eye and then that
Correct,
is
correct.
lesser cataract, they may not
Correct,
agree
correct.
much.
So practically the eye with more cataract.
And that eye we cannot make it myopic also, because they will not
correct.
get impressed with the good distance which they get.
Absolutely, sir. Absolutely, sir.
Thank you very much. Any
Thank
doubts
you.
on this? Because it's a very crucial thing to make people have almost no photic phenomenon, but they get very useful intermediate and near vision. This is a very crucial step ahead, and this will encourage more people to take up or use EDOFs rather than multifocals, especially in people who are demanding like this for
Correct,
their
correct.
multiple activities.
Correct.
And thank you very much.
Thank you,
Thank
sir.
you,
Thank
everyone.
Thank you to the audience.